Okay, good. Good afternoon after a break. I'd like to welcome all our panelists back and welcome our attendees and give a special welcome to our last two speakers. First, we're going to have Dr. Jeffrey Staab, who's a professor of psychiatry and chief of psychiatry at the Mayo Clinic, who's going to talk about his research with PPPD and his clinical work involving PPPD, and also some of his work where he was a member of the 2020 National Academy of Sciences, Engineering, and Medicine panel on Havana Syndrome under the leadership of Dr. David Relman at Stanford. And then after that, we'll have Dr. James Giordano, a professor of neurology and biochemistry at Georgetown, and also a adjunct professor at the National War College, and who's done a lot of work with DARPA and the Institute for Defense Analysis, talk about his views of the Havana Syndrome and how to tie the different threads together that you've heard about in the morning with the clinical presentations and the most recent presentations kind of from the US government's 30,000-foot view, along with a very human and personal story from Mark Polyperopoulos of the victim impact of someone who's suffered from Havana Syndrome during his work with the US government. So with that, no further ado, Dr. Staab, you're on.
Great, thank you. All right. Well, I sincerely appreciate being part of the panel today. I thank Dr. Tominga, Dr. Dekleva, and the UT team for hosting this, and hope that I can make a small contribution as we go forward in the next for the rest of the afternoon. So, as Dr. Dekleva said, I did serve as one of two psychiatrists on the National Academy's panel. I'm also a member of two scientific societies, and I was the chair of the Barony Society. That's an international neurotology research society that defined persistent postural perceptual dizziness. I'm not going to talk about grant fund things directly related to my grant funding or commercial interest, but I am, for the clinicians in the audience, will mention some off-label uses of two classes of antidepressants that we can sometimes gain benefit for patients with PPPD. So we'll talk a little bit about relationships among structural, functional, and psychiatric illnesses. Just a brief overview. You've heard some of this, but I want to put it in context. And I'm just going to point out a couple of specific things from the National Academy report, and then we'll delve into PPPD specifically, and as it's related to U.S. government employees from the Havana mission, which were the ones that we that we looked at from the national academies, with a few from China. So this was my introduction to syndromes like what we're trying to figure out with the Havana Syndrome. I was a naval medical officer, finished my training at what was then Bethesda Naval Hospital, now Walter Reed, and on active duty during Operation Desert Shield and Desert Storm. And we saw at that time some of the first sailors and Marines who returned with what we now call Gulf War Syndrome. And this was a chief petty officer, a bulldozer driver in the Navy Seabees, who said, "Doc, why my head case just because you can't figure out what's wrong with me?" And what he was saying was something that is a legacy of 20th century medicine that has crept into this problem. And I want to put it in this context. There is one and only one time in which B equals not A, and that is when we know all of A, all of B, there's a firm line between them, and there's no overlap. But in this area, as in lots of areas of medicine, there is the unknown, and the A's and the B's don't have firm lines and boundaries, and they overlap. So under that circumstance, it's impossible to find anything solely by what it's not. And there are no diagnoses of exclusion, even though we use that term in medicine a lot. It's logically impossible unless we know everything. So this is the trap that that we've heard both patients and a lot of doctors, press, and others that have fallen into this when it comes to trying to think about the Havana Syndrome. So what's an alternative? And this is beginning to move forward. You heard some discussion about this from our UT colleagues this morning. So rather than taking this approach of ruling out stuff, ruling out all the structural things, and then coming to the default conclusion there must be psychological factors, the approach now that is changing but not yet changed in medicine is to rule in. And that by that we mean look for the structural, metabolic, and cellular illnesses that may be present. Look for psychiatric disorders and psychological factors. Look for changes in functioning and functional disorders. The important thing here is that if I identify something in the structural, cellular, or metabolic range, it only tells me that. It tells me nothing about the presence or absence of other of the psychiatric or the functional problems, which each have to be evaluated in their own right. So a shift to this multidisciplinary approach where each specialist contributes to the evaluation of the presence or absence of signs and symptoms and test findings in his or her area of specialty, building in a layered way the overall picture of which patients have, both from a clinical standpoint, but really importantly from a research standpoint. So what do we mean by functional? It turns out it's been around in medicine for a couple of hundred years. And so here's a quote from a Scottish physician from 200 years ago, and saying that function simply means a change in the mode of action of an organ, unconnected to any perceptual structural alteration. So this idea that functional is somehow, a synonym for psychiatric, psychogenic, that's all 20th century stuff. It originally just meant change in functioning, hence the term functional. And when we defined 3PD now a few years ago, we specifically said that we were going back to that original origin and dissecting out this blend between psychogenic, psychosomatic, and functional that had really settled into the 20th century. Now back to what I just showed on the last slide. So a couple of things that I want to point out about conclusions from the National Academy Standing Committee, specifically now related today to PPPD, and that is it's really focused here on the more persistent symptoms. So you've heard a lot about those acute symptoms, but when it comes to 3PD, it's really focused on what is persisting in terms of trying to explain a portion of the symptoms that have continued to plague affected individuals. The other thing that I want to say is that as we went through various test results and so forth, the initial tests from Miami, from Penn, that our Canadian colleagues did on their diplomats, were focused on selected tests that were clinically relevant, and also the researchers involved pushing into using novel methods of discovery. And one of the challenges there is if you're researching a novel entity or an unknown entity with novel methods and you find something, the scientific obligation is to sort out whether what you found is related to the new method or the new problem that you're trying to address. And that is harder to do than it sounds. And so you have to have some both skepticism and humility about reaching conclusions too quickly. So the patients who were examined at the NIH Center, a quarter of them received the diagnosis of 3PD, and there was one other person who shared that person's medical records with the panel, who had consulted a separate tertiary neurology center and also received the diagnosis of PPPD. So that was not a diagnosis that we on the standing committee rendered. We did not render any diagnosis, but we were aware that these two specialty areas had diagnosed one patient in this case, and a quarter of the ones that were seen in that initial cohort at NIH with this functional neurologic symptom. I also wanted to draw attention to one other aspect about the standing committee's conclusions. A lot of attention was paid to the radio frequency energy aspect of the report, but but I've not seen a lot of people focus on this specific thing, and that is that there is many people have focused on did whatever this may have been damage the brain structurally or damage the inner ear structurally. And it's really important to recognize that it's not necessary that a structural injury occurred, only that the brain or the inner ear was stimulated. And so it is possible, theoretically possible, that whatever source could have been involved, again, with those small number of cases, like what the CIA interim report recently said, what we said from the National Academy, that a stimulation could have occurred, leaving no tracks of brain injury behind. Now, that doesn't mean there wasn't any, but it is possible that the brain could be stimulated and leave no tracks, but yet cause the kind of disruption that we've seen. And the second thing that we said is that psychological and social factors can be involved potentially in some of the early symptoms, particularly those that are a little less distinct, and that we have to consider those as contributors to the chronic outcomes of patients. And importantly, from the idea of ruling in, not to the exclusion of structural, metabolic, or other factors, but as part of the overall picture. Okay, I'm going to take one diversion from 3PD just to comment on this aspect. So, were or are U.S. and government employees and their families particularly at risk from a psychological standpoint? And I think the answer to that is that nobody is invulnerable. And this quote here is an engineer. I was an engineer before going to medical school. And one of the things that we were taught was no matter how perfectly we design something, the very fact that we were designing something meant we were designing in its vulnerabilities. And that applies to human beings too. So our very dedicated, very heroic people who served and continue to serve us, by the fact that they're human beings, do have some vulnerabilities built in. That doesn't make them more or less vulnerable than others, but we can't ignore the fact that that those things are there. I also want to make sure that people understand this issue of the mass psychogenic illness. Since the 1960s, there have been very specific methods for identifying the presence of mass psychogenic illness. That is not so very different to how we identify other contagions. So you evaluate the index case, you perform the contact tracing, you find how the psychological factors spread, and rule in the presence of that. And given that there are no data that have been made public about that, it is only speculation that allows people to suggest that mass psychogenic illness was part of this. And frankly, the overall pattern, index case to contact tracing, there are some real some difficulties in even foreseeing that could occur. But it really is important, if somebody's going to raise that question, that they do it with data, because there are strategies and methods that are well established for putting forth that hypothesis. All right. Switching over then to PPPD. So it's a new term, but it's not new at all. It has been there similar syndromes were described as 150 years ago. There was a debate back then about how much visual anxiety or some blended aspects of this disorder of dizziness and unsteadiness occurred. Then we got into the 20th century, where we had this dichotomous hierarchy. You were either thought to have psychogenic dizziness if nobody could figure something out structurally, or everything was attributed to an inner ear or brain problem if there was any inner ear or brain problem found. So again, the dichotomous thinking. Then towards the latter half of last century, people started to describe a variety of different syndromes that were reminiscent of those 19th century entities. And at the 10 years ago, the Barony Society put together an expert panel, and it completed its work in 2017 to define 3PD. And here is its definition as part of the International Classification of Vestibular Disorders. There is a briefer definition that will be included in ICD-11. This is a chronic condition, so 3 or more months of unsteadiness, dizziness, non-spinning, vertigo. Symptoms don't have to be present for every single moment of every day, but rather occur in long periods. Often patients will have a brief respite of symptoms when they first awaken in the morning, and then within 30 to 45 minutes of getting up and around, the symptoms start to settle in. Once the symptoms are present, they don't have to be provoked in any way. They seem to wax and wane, but when people are upright and moving around, either actively or passively, like in a car, and especially when they're exposed to moving or visually complex visual patterns, the symptoms can increase. And I apologize, the announcement in the background here at Mayo Clinic for everybody to wear their mask is going on. That'll finish in just a second. So the other important thing is that 3PD is a condition that's triggered by a variety of different kind of events that can cause acute or episodic vestibular symptoms. So you can have vertiginous, ENT, medical, psychological distress, other factors that can cause someone to feel unsteady or dizzy, and under the right conditions, go on to precipitate 3PD. Now, since that definition was published in 2017, there have been a number of epidemiologic studies done around the world showing that it is actually fairly common. So it's not a rare thing. And you can see that in referral neurology clinics, so university or hospital-based neurology clinics, among patients with dizziness, 1 out of 5 has 3PD as a diagnosis. If you get to subspecialty dizziness clinics, like the one run by our colleagues in Ottawa or ours here at Mayo Clinic, it approaches 50% of patients. Again, that's a selected group. Even in general internal medicine clinics, however, among dizzy patients, it's about 1 out of 6 or 1 out of 7 patients with persistent dizziness who have 3PD. Now, this is what I was mentioning before. So the finding of 3PD in a portion of individuals with the Havana syndrome, unfortunately, does not tell us anything about the potential triggers, because the potential triggers can span vestibular, either peripheral vestibular syndrome, so inner ear or brain problems, anxiety or stress related situations that produce an unsteady, lightheaded, fuzzy-headed kind of feeling can trigger it. Migraine, traumatic brain injury, autonomic problems, and other metabolic disorders, blood sugar derangements, those kinds of things can all be triggers. So the finding in patients who are now months into or years into Havana syndrome that they may have 3PD as a potential explanation for some symptoms does not allow us to back up and say specifically what was the initial trigger. We do have some research that's been done over the years to look at how do we get from an acute event to chronic dizziness. And this is a study from an acute inner ear infection that causes sudden onset of vertigo, sometimes with hearing loss, sometimes not. And the patients were followed over a year, looking at the nature of their chronic dizziness. 2/3 of them recovered, 1/3 did not. But importantly, among those who didn't recover, the majority of them showed good healing of any inner ear injury that they may have had. So they compensated, or their brain adjusted, their inner ear healed for the initial deficits that was caused by the infection. So then the question is, well, why then did this group stay dizzy? And one of the predictors, and you heard this earlier from Dr. Cullum, and looking at one predictor of persistent post-concussive syndrome, is that acute anxiety in the context of the initial, excuse me, pardon me, in the context of the initial set of symptoms can be a trigger for ongoing illness. And as Mark Plimeropoulos described earlier today, acute and unexpected vertigo is a very terrifying entity. There was an emergency room study done a few years ago in which patients were asked, what was your emotional state with the onset of whatever symptoms you presented with? And it was not acute chest pain. It was not acute shortness of breath. It was not an acute car accident, but rather acute onset of unexpected vertigo that was the most terrifying symptom that patients reported to emergency rooms with. Okay, so I'm just going to give you a couple of examples of the physiologic and psychological research that's been done by our team and others around the world in trying to sort out what is happening in patients who have this persistent condition. So one of the ways that we can do this is by using this kind of complicated posture platform, and what you can see is that there's a person standing with and we can project a variety of different images, static and moving images, into that concave screen, and also the platform on which the patient stands moves. So sometimes the platform is fixed and sometimes it sways with them. And what you can see is as we start to change the cues, so the visual cues and the cues of the pressure of the feet on the floor, we can cause people to have a bit of a decline in their stability. So here is normal individuals in blue, and so the test is challenging as it moves forward, and you have both motion of the visual field here in condition number 6 and motion of the floor. But patients with 3PD start to show that deterioration much earlier and to a larger and to a quicker extent with less provocation than normal individuals. And importantly, even less provocation than patients who have recovered from an inner ear injury. This also is a very interesting research study that was published a couple of years ago from a group in Chile. This is let me explain this a little bit to you. So this is now done virtually on the screen. When it's done with rodents in the laboratory, it's actually done in a tank of water. But virtually on the screen, this is a tank of water virtually presented. And then there's this platform that rises above the water that can be visible. And you have some practice trials here. So where the person is placed here and said, move yourself over to that platform. So they get 4 times in which they can do that. Then the platform is dropped away below the water line, so it's not visible. And the subjects are said, start here at the end and move over to where that platform was. And these, you can see there's pictures along the side walls of the video screen that are orienting cues. And the last task is that the person is placed anywhere in the tank and said, get over to that platform. So what you can see is here's the control group, and they, without any difficulty in the B and C test ones, move from the starting point either there or anywhere else, clearly to where the platform is located. No trouble, they get right there. This is a group of patients who have an inner ear injury, so a chronic inner ear injury. They have a little bit more trouble. You can see in the white, they wander about just a bit, but still end up quite well in the area of the fixed platform. These are patients with 3PD, and you can see they're pretty much wandering aimlessly. Now remember, patients with 3PD here do not have ongoing structural injury to their vestibular system, but the development of these functional shifts that occur with 3PD make them have great difficulty with spatial orientation. So this is as an example in which functional shifts in brain activity and connectivity can really degrade performance on a relatively simple task. So I put this up here because to drive home the point that we don't absolutely need to have an established sort of smoking gun of brain injury from a structural standpoint to see that patients can suffer greatly in terms of their daily activities and abilities to perform tasks that we take for granted. Here may be some of the reasons for that. This was a study that I did with colleagues in Korea, in which we looked at, this is a functional MRI, so it is not showing structural injury, but connections. How is one part of the brain connected to another? And what you can see here is that this area of the left hippocampus has markedly decreased interactions with multiple other areas of the brain that are involved in the process of spatial orientation. This area of the brain also is involved in working memory, or that sort of short-term memory that we use to do tasks. And so patients with 3PD versus healthy controls show a reduction in connectivity, this really important area that allows us to sort of go about our day-to-day business, know where we are and what we're doing when we get there. Here's another example of functional imaging studies, and I want to take a few moments to take you through this because it drives home this point of overlap of structural, functional, psychological processes. So these are patients with 3PD. They were placed in the research scanner and put through a virtual reality roller coaster ride. So while they were in the scanner, on a screen, they watched a virtual reality roller coaster ride. So you've got an external stimulus, so an environmental motion stimulus. You have a group of patients who develop 3PD because of a structural injury to their inner ear, in this case, an infection. And what we found was that the vestibular region of the brain was reduced in activity. The visual region of the brain was increased in activity. That's called visual dependence. So shift from relying on your inner ear gyroscope to relying more on visual cues. The intensity of that shift in the visual cortex was directly related to the severity of symptoms that the patient had, and the connectivity of these visual regions with areas in the front of the brain that regulate eye movements and regulate emotional responses to stimuli was modulated by how much neuroticism, which is sort of a worrywart nature. This is not an illness. This is how worrywart or relaxed somebody is, but that personality trait modulated this connectivity differently in patients with 3PD versus healthy controls. So let me go through that once more. Again, we have patients who had a structural problem that triggered a functional illness. And when we exposed them to an environmental stimulus, the activity of their brain was in proportion to the symptoms that they were experiencing, changes in activity in proportion to the symptoms that they were experiencing, all modulated by a natural personality trait. The importance of this is that engineers have done a great job in giving us really powerful tools for sorting out what the brain is doing in terms of its structure and function. But if we do not associate, if we don't measure and correlate structural, functional, and psychological variables, we will make no sense out of the images that that high technology produces. So our obligation as researchers is to make sure that we take this multidisciplinary approach to understanding a problem like 3PD in this case, or Havana Syndrome, when we begin to collect data on individuals that are suffering from it. Okay, back to more the sort of the clinical standpoint. So we use this information to describe the following kind of scenario to patients. You had a precipitant. It may have been an inner ear problem. It may have been another medical event. It may have been a very stressful or anxiety-provoking situation. You shifted strategies because if your inner ear is not working, you have to rely on your vision a little bit more. If you find yourself off balance, you're going to use a little bit more of a high-risk postural control strategy, like if you would if you were walking on ice or at the edge of a cliffside. And you'll become more vigilant about your environment because it does not feel as safe. And then after time, most people will have a recovery, inner ear recovery, medical recovery, behavioral recovery, but under certain circumstances. And one of those circumstances is acute anxiety. Again, not freaking out, but becoming more vigilant about your body and your surroundings. You can settle into a persistent pattern in which you don't shift back from that high-risk postural control strategy, kind of stay stuck there. And then you're in a vicious circle of when you're exposed to some of these provoking factors, like your own motion or complex environments, that your brain is processing that information differently, driving your postural control strategies differently, and that feeds off of one another and stays in this perpetual loop. Now, not all patients, but many patients with 3PD will develop anxiety or depressive disorders. And I showed you earlier how there can be dysfunction in spatial orientation and what's called cognitive flexibility. Okay, so how do we treat this? Well, patient education, you've heard a little bit earlier about vestibular therapy. I'll talk some about medications and the role of psychotherapy and then finish in time for questions. Okay, so the role of physical therapy, first and foremost, is to normalize stance and gait, to allow people to be able to move without thinking about it. As one of my colleagues from Luxembourg says, the only time we think about our balance is when it's goofed up. Otherwise, it's an automatic process that we give no second thoughts to. And so our first goal is to get people to be able to walk and move about in that kind of a way, distribute their weight normally on their feet, and then improve the tolerance, as you heard earlier, improve tolerance for one's own motion and for the movement of visual stimuli. This happens to be the most difficult task. Those visual cues and sensitivity to visual cues seems to be one of the more difficult things to rehabilitate with people with 3PD. We do have both retrospective and prospective studies that show that vestibular rehabilitation that's individualized for patients is beneficial for at least half of patients, moving them from impairing levels of symptoms to sort of nagging in the background levels of symptoms. All right, medications. This was accidentally discovered by our group when I was then at the University of Pennsylvania, and also simultaneously by a group of colleagues in Japan. And what we were basically saying to people is, we don't know why you have chronic dizziness, but we do know that you've got this anxiety and depression that's running along with it. Why don't we treat that? Here, take this antidepressant. And people came back and said, I'm not dizzy anymore. And we said, well, we didn't really expect that, but okay. And we saw it again and again, so we began to study it. And it turns out that the group of medicines that are called SSRI, so in this case, sertraline, also known as Zoloft, or medicines like Effexor or venlafaxine or duloxetine, also Cymbalta, that those two groups of medicines seem to be able to cut the symptoms of 3PD in half. So this was our original study here from 2004. This is a larger study that was reported a few years ago from a group in China, showing that an adequate trial of at least 8 weeks or more of these medications could cut symptoms in half. And what this difference is adding some psychotherapy around body vigilance, around catastrophic thinking, and I'm never going to get better, it's always going to be this way, that kind of catastrophic thinking, that adding those psychotherapy improved on top of the medication response. And there are no large controlled trials that have yet been done, but of the reported studies from around the world involving now more than 300 patients in some sort of an organized clinical trial, we've been able to show that these groups of medicines can improve symptoms. And very importantly, that improvement is not mediated specifically by improvements in anxiety and depression. Anxiety and depression do improve. If they're present, they do improve. But in a number of our studies, we had patients who I could not diagnose with any anxiety or depressive disorders who also responded well to these medications. So it is not purely psychosomatic manifestation of anxiety or depression that we're talking about here, nor does the treatment response require a mediation through psychological factors. Okay, psychotherapy is also an important part of this. It has a specific target, and that is to reduce that body vigilance, to reduce associated fear or anxiety, and kind of to reframe the kind of cognitive symptoms. I think, you know, Mark Polymeropoulos talked so much about what the team at Walter Reed was able to do, sort of restore hope and reduce some of this sense of being stuck forever in a catastrophic outcome. So our psychotherapy colleagues can have a very important role to play in the overall treatment strategy of this disorder. Now, there's some limitations of 3PD, and they apply not only to Havana syndrome, but to others, and that's depicted here. 3PD has symptoms that overlap with other problems, overlap with other chronic vestibular disorders, overlap, as you've heard, with TBI, with chronic migraine, with autonomic dysfunction, other chronic neurological disorders, other medical conditions like chronic heart failure, and primary and secondary psychiatric disorders. So no individual symptom of 3PD is unique for 3PD. The syndrome is relatively unique, but does overlap with other things. And it's also the case that amongst that first cohort that was evaluated at NIH, only a quarter of patients had symptoms that fit with 3PD. So when it comes to Havana syndrome, we have a syndrome that's been defined that has growing evidence about what its physiology, psychology, and brain responses are like, but it only applies to a portion of patients and may only explain a portion of their symptoms. So it is not sort of a be-all and end-all of the answer for Havana syndrome, but when it is present, provides a couple of three specific treatment strategies that can be incorporated into an overall treatment plan. So in conclusion then, Havana syndrome is very much a 21st century malady. We've seen similar kinds of processes before. People have pointed out some of those, like Gulf War syndrome, but it does absolutely require a 21st century approach to diagnosis. This rule in, find the evidence for structural cerebolic or cellular metabolic illnesses, find out whether there are psychological factors or psychiatric disorders present, and then carefully evaluate, measure, and treat the functional shifts in sensory processing, sense of space, postural control that exists in patients who suffer from this problem. When it comes to Havana syndrome, 3PD is it can be part of the approach to evaluating this and is important for people who meet the diagnostic criteria, but we should not try and stuff all of their symptoms under the rubric of 3PD. And more broadly, psychological and social factors are contributors to chronic morbidity, both in patients with 3PD and, as you've heard, in patients with Havana syndrome, and that a comprehensive rehabilitation strategy that accounts for any of these factors that are ruled in is necessary to promote maximal recovery. Here's a few selected references that can be helpful for people, including the diagnostic criteria, some of the epidemiologic studies, a review of neuroimaging findings, and then a couple of things with regard to treatment. And I'll stop there and take questions. Thank you very much.
Thank you, Dr. Staab, for a fascinating presentation. We have several questions to already address to you. First, Dr. Dave Charney asks about other models for consideration of Havana syndrome, such as carbon monoxide poisoning and other types of brain injury. And one of the things that Dr. Charney asks is, because we know hyperbaric oxygen therapy is useful in brain conditions such as carbon monoxide poisoning and neurological decompression illness, has hyperbaric oxygen been considered as a treatment for PPPD?
So for PPPD, no, because we don't we don't have evidence that the mechanisms that sustain 3PD are related to structural injuries that might be rehabilitated with hyperbaric oxygen. With I would to answer the question about carbon monoxide with directly or other poisonings with directly related to Havana syndrome, there is a section in the National Academy's report that talks about toxicology and the possibility that these symptoms may be related to that. And really the pattern of illness and the pattern in which it developed just didn't support that. So again, there were toxicologists and epidemiologists who were with us on the panel who were able to lead us through the evaluation of that. The Cubans at the time were spraying heavily for mosquitoes because there was the Zika virus infestation then at the time, and that's one of the ideas that people put through, that some of those organophosphates may have been part of this, but the data on the ground and the overall development of the illness just didn't support that.
Two other questions. One from Dr. Lakritz, thanking you for your talk. Have you found a therapeutic window in which it's important to initiate treatment for triple PD in order to achieve an optimal outcome?
Yeah, Dr. Lakritz, thank you for that question. So there is a hint, not so much an optimal window, but in reports of studies, so that we reported on medications that we looked at when we looked at some of the rehabilitation therapies, and that psychologists have reported, the earlier the intervention, the better. So it is not that patients will have no benefit if we catch them late, but it seems like the extent of the benefit is not as great as if we catch them early. And that applies to all three primary treatments for the disorder.
Another question is, could you comment on, since you talked about some of your MRI findings, comment on the 2019 VERMA study and your opinion on that?
Yeah, and that's something that we looked at extensively within the panel, the National Academy's panel. We had both radiation physiologists and neuroradiology experts with us. And what I would say, based on their input and also my work with teams that have looked at this, is I would go back to that comment that I made earlier about using an experimental protocol for an enigmatic illness, and that you have to take into account that you're using a technique that is not well established and not well normed. So if you find a difference, you don't know right up front whether that difference is related to the technique that you're using and therefore found something because you have a new technique, or whether it's related to a difference in that's due to the illness. And as we heard earlier in the morning, in order to validate the methods, you have to have multiple comparison groups. So an entirely normal comparison group, a group with known illnesses, and only after you do that can you really say with a surety what it is that that you're seeing on the scanner. So the challenge in the interpretation from the Penn group was that because they saw things that they hadn't seen before, that they interpreted that as evidence of brain injury, and while that is a possibility, because they were using techniques that were really sort of at the edge of MRI scanning capabilities, you really can't say that with a surety.
Okay, there's another question from Dr. Barshikar. What is your best recommendation in terms of treatment-resistant triple PD cases? What approach is your team taking in those cases?
Yeah, thanks, Ken. What we do with patients who have not responded adequately to these interventions, and that would be about 20% of the people that we see by the time they get here to Mayo Clinic. About 1 in 5 maybe don't respond to the level that we would want. We then use our multidisciplinary rehabilitation approach. So our pain rehabilitation colleagues and their rehabilitation is not just pain, but groups of patients who have chronic and persistent physical symptoms. So, like what your team is there at UT, Ken, with some of the long COVID patients, patients with fibromyalgia, patients with postural orthostatic tachycardia syndrome, those kind of things. We take that multidisciplinary rehabilitation approach. And we have a 3-week intensive program that we have them go through.
I have another question that's come up that we've discussed here with our multidisciplinary team. Have you seen any benefit to using augmented reality or virtual reality devices to help in the rehabilitation of patients with more severe triple PD? I'm thinking of like Oculus Rift and things like that.
Sure. The group that actually did some of the earliest research on that is in London, and they showed that using virtual reality could be a worthwhile augmentation strategy for traditional rehabilitation techniques. I would have one caveat to that, and that is that when you place somebody in Ocular Rift or any other, even very good virtual reality environment, it is not entirely normal. And so you set up a bit of a conflict between visual motion stimuli, the seat of their pants saying that they're not moving, and depending on how they're moving their head, whether or not they're getting normal vestibular stimulus. And so some patients with 3PD find that sensory conflict to be troublesome. And so if for people who don't like that, we really emphasize rehabilitation with natural stimuli.
There's another question, Dr. Staab, with respect to Havana Syndrome patients who experience dizziness. How do you and your team differentiate between episodes that are related to directed energy and episodes that may not necessarily be related to directed energy?
Well, frankly, there isn't really a way to do that. The only thing that I would say is that if we look at the core group of people who seem to be first and most dramatically affected in Havana, those are the ones that we studied. The kind of, and people have said this before, that group of auditory and vestibular symptoms is unusual. We don't see that in neurologic illness that there's natural vestibular illness. And it's actually not something I've encountered even in patients with delusions and other primary psychiatric disorders, that specific combination of symptoms. So that's really the one where we would say perhaps we contribute that to the inciting events that are still unknown. But if I was to see a patient with Havana syndrome that told me, in addition to the chronic day in and day out symptoms, I have these episodes, I would look to migraine, I would look to other comorbidities that can develop in patients with 3PD rather than suspect that they were necessarily continuing to be exposed to an external force.
We have time for one more question from Dr. Chris Gilbert from Psychology Today. Dr. Gilbert asks, what practical immediate advice would you give to somebody experiencing what could be Havana syndrome? Get out of the room, go back in to see if the symptoms change head position and orientation to see if there's a change, get aluminum foil around the head. What else?
I'm not so sure that I would be the best person to say, well, what are you doing when something bad is happening? Or that I would be willing to say, please do this when something bad is happening to you. I think that the best thing, given what we know, what we don't know about this, would be to try and eliminate the stimulus and then seek help. Something that these days now our diplomatic corps and others assigned overseas have been encouraged to do more. I'm not so sure that any exposure to a potentially dangerous, that I would ask anybody to approach any exposure and kind of keep investigating it on their own. So I think trying to eliminate the stimulus, to remove yourself from the stimulus and to seek help would be the most prudent thing to do.
Okay, thank you, Dr. Staab, for a very wonderful and informative presentation. And